Okay, this is Michael from Blue Sky Bio. I'd like to welcome everybody who's joining us for the presentation this evening. Tonight's presentation is part of the 2017 webinar series organized by Blue Sky Bio. Tonight's presentation is the 14th webinar starting from 2017. So there's really a tremendous amount of free educational material on all sorts of topics connected to guided surgery and implant placement, accessible via YouTube and the Blue Sky Bio website. So we definitely recommend taking a look at past recorded webinar presentations. And of course, we still have a lineup of fantastic topics and speakers coming in future dates. A few technical things before we get started. There's a link for the webinar attendance form next to the video screen. So click on that link and enter your details into the webinar attendance form so that we could send you the CE credit. That same chat box is available. You can enter questions during the webinar presentation and they'll be addressed at the end of the presentation. But you could go ahead and enter questions throughout and they'll be addressed at the end of the presentation. For tonight's presentation, we have the honor of hearing from Dr. Kotel. Among his long list of qualifications, he's a national and international speaker with extensive knowledge in both radiology and 3D imaging fields, with a specialized focus on cone beam CT imaging technology. He now serves as the director of 3D imaging at Carestream Dental. Tonight, we have the pleasure of hearing him present on the topic of CBCT imaging in guided surgery.
Okay, so adjacent anatomy of implant sites is also to be considered. Now, that by adjacent anatomy, what do I mean? I mean, you might have a single implant site, but the anatomy of the tooth next to it, the anatomy of the crestal ridge around it, next to it, or even a kind of pathology probably sitting next to the implant site is also to be considered when it comes to CBCT and implant analysis. Quantity of bone, just as it described, as it's written out there, it just means the amount of bone that is present at the implant site. Now, this can be physically measured. It is important to assess this because this directly affects how you do your surgical guides, or if you're not using the surgical guides, how you pick your implants, and a whole series of other things. The measuring tools are usually programmed and designed for this purpose. Quality of bone can be assessed in multiple ways. We will be going through a few ways to look at the quality of the bone. I will give you a brief idea of how to work with the quality of the bone. So that is also one of the most important things, since the traditional methods of measuring the quality of the bone are not relevant in 3D imaging. It is important to use a different set of standards, a different set of parameters to assess the quality of the bone. Assessing the borders of the implant site, another critical factor, because once you identify the implant region, the borders make a clear relevance because you do not want to go beyond the borders. You might want to stay limited to a certain areas between the borders. Also, you do not want to violate the borders as well. So a few important things to consider as you jump in and start doing planning for implants. Typically, broadly, of course, we can classify anatomical structures between maxilla and mandible. Now, when you take the maxilla, although there are many structures, more structures in the maxilla and mandible than what I'm presenting today, this is clearly in relevance just to implant imaging as such. We have the maxillary sinus, we have the ostium. Of course, we will be going through all these anatomical structures as we go through and explain a few ways to look at these structures. The buccal and the lingual dimensions of the alveolar crest, this is also very critical to note because the crestal ridge differs from different areas of the jaws. The incisive canal, another important structure that you would want to note in the maxilla, not so important in terms of actually doing implants because you will be doing either on one of the sides of the incisive canal and try not to actually perforate it or do any of those sorts. In the mandible, of course, a little bit more bigger and more important structure. You have the inferior alveolar nerve canal. It is imperative to identify the course of the nerve canal for the sake of a safe treatment planning. You have the mental foramen, you have the lingual foramen. There's mental foramen bilaterally and one lingual foramen in the genotubercle, right in the midline. They all have their own importance and in terms of neurovascular bundle that it enters or exits out of it. Accessory foramens. Now, accessory foramens may not be typically visualized in every single individual jaws as such, but literature indicates a good over 30% of all individuals do have accessory foramens. You would particularly not be looking at accessory foramens, but in case in case you come across one of them, it's probably around in the mandible, around the premolar canine region. So it's very critical to keep an eye for any accessory foramens that could come out of the normal anatomy as well as a variation. Extensions can happen in inferior alveolar nerve canal. Now, by extensions, I mean it could be either a straight extension or it could be a loop. Now, the words are anterior loop and extension are concurrently used. So the idea being that there might be an extended portion to the inferior alveolar nerve canal. Condyles may not have any kind of relevance to implant imaging, but as such, when you do mandible scans, certain large field of view mandible scans, you might end up with a little bit of condyle. So it is imperative not to, for the sake of completeness, not to go ahead and, to go ahead and actually evaluate the condyles as well. So when you look at these structures compositely, what are the few things that you definitely want to keep in mind as a component to these structures? When you look at the inferior alveolar nerve canal, when you look at the mental foramen, the lingual foramen, the primary thing that you're trying to assess is the neurovascular bundles that are passing through these. You do not want to violate this. You want to keep an idea, even when it comes to accessory foramens, this is one of the primary concerns. You know, what is an accessory foramen for? It usually has an accessory blood vessel or a nerve ending that is passing through it. So that is the critical nature of looking at any kind of neurovascular bundles, or the need for looking at those bundles. The paranasal sinuses. Now, I had mentioned the maxillary sinus. I'm going to take this a little bit further and say paranasal sinuses, because when you do maxillary scan, there's a very good chance that you get beyond the maxilla and the paranasal sinuses, which is the sphenoid, the ethmoid sinuses that could get captured within the scan as well. So in matters of sinus evaluations and in terms of actually evaluating the entire image, please be aware if it's present, you need to be able to look at it and look for any kind of occult pathology that could be possibly hiding. The cortical boundaries of the implant site, or in general as such, indicate the intactness of the bone. There are various other disease processes that can be assessed from the cortical boundaries. We'll jump into that a little bit and give you a brief idea. But the cortical boundaries gives you an idea to assess the amount of bone, to the first slide that I showed, where the quantity of the bone. So when you have enough thick cortical boundaries, when it's well described, you know there's a very good chance that you have a good healthy bone inside. The cancellous bone is much more in terms of quality of the bone. So within the cancellous bone, you would be looking for a few things, and as we go through, we will come to it. And this indicates quality of the bone. It is critical to not overlook the cancellous bone and the cortical bone for one main reason, because the traditional methods of density of bone are not applicable when it comes to CBCT imaging. When it comes to implant imaging, the primary goal is to achieve cross-sectional images. What is the purpose of the cross-sectional images? Cross-sectional images gives us the buccal lingual dimension. What you see over here is a buccal lingual dimension clearly. And by looking at the buccal lingual dimension, you're able to assess the height and especially the width. This is the third dimension, or the component that's missing in two-dimensional radiography, which leads you to do. So once you have the buccal lingual dimension, you are able to now see how that site in terms of the height, width, and the depth, which is the buccal lingual component to it. So not limited to But at least when we look at an implant site, if I were to pick 3 things to keep in mind every single time uh, uh, when you assess an implant site, I would probably have these 3 things to look for in my mind. So the yellow component, of course, the yellow mark over there, circles indicate the inferior nerve canal. Now that is pretty much standard, but what else do we look for in the buccolingual dimension? We look for the lingual undercuts. Lingual undercuts occur to a certain degree in all individuals. They are not to be treated as a negative connotation. Should not have a negative connotation when it comes to implant planning. Negotiating the lingual undercut is a part of the virtual treatment planning that you do with CBCT and any kind of 3-dimensional images for that matter. Knife edge ridges. If you have areas that are edentulous for a long period of time, sometimes even just post-extraction, just incomplete healing, or healing process that has not been that is just stunted at some point, you would probably see knife edge ridges. Now, knife edge ridges may not be consistent along the entire jaw the same way. You might have different areas with knife edge ridges, some of the areas may not have, and most commonly these are seen in the anterior areas where there's slightly lesser bone, thus increasing the resorption of the crestal ridge. The ridge angulation is another factor that has come into play ever since 3-dimensional imaging has become important, or a vital part of the implant imaging. By ridge angulation, what do I mean? The slight difference between the lingual undercut and the ridge angulation is the ridge angulation usually happens above the lingual undercut with the rest of the crestal ridge. This can change over a period of time. It could be a factor. It could be a physiological change, or it could be age-related change. But this indicates the angle in which the crestal ridge is present. But once the crestal ridge is angulated to a certain degree, how do you accommodate an implant in that? There's literature saying that about 10 to 15 degrees is forgiving, even up to 17 degrees could be forgiving, and anything about that could cause possible destabilization of that implant in load-bearing areas. That's mainly in the posterior areas. So planning your implant all the way from the ridge to the crown is very critical. Now, I did mention the knife edge ridges. Now, knife edge ridges, I did want to show you a series of images that shows the point that I was trying to make. In these images, you can clearly see in some areas there's probably enough ridge width, but when it comes more anterior, you're unable to see the same amount of width. So even within a certain amount of jaw, in a single jaw, upper or lower, you could still end up getting different areas of ridge width. So it is very important to evaluate the entire sections, the adjacent anatomy, and of course the rest of the structures as well. Inferior alveolar nerve canal it's very important. Keep in mind, inferior alveolar nerve canal is very easy to identify in most areas. There are certain times when you may not be able to identify the inferior alveolar nerve canal, and when it comes to that, what are the things to keep in mind? I would just make a list out as we go through various things when it comes to images. But keep in mind with the inferior nerve canal that you would also have some anterior loops or extensions, as I mentioned. Post-op evaluation, there's absolutely no limit on assessing the post-op evaluation using CBCT images. You may not want to use 2-dimensional images as a direct comparison for post-op evaluation, but it's acceptable to do 2-dimensional images such as PAs. But just keep in mind they are not exactly the same. So there is a little bit of difference when it comes to CBCT and 2-dimensional images. Now let us take a look at planning as such, or the images as such, and then jump into probably planning an implant as we go through this. So the first thing that I want to bring you to is the normal anatomical structures that we talked about. So in the maxilla, we talked about the maxillary sinus, the paranasal sinuses. So if I were to look at this coronal image right over here, this is a great view. Now, I have used a very large field of view. I do understand that most of you may not be using a large field of view for the sake of implants. That is perfectly fine. I use this for the sake of completeness, so that I don't have to switch between different scans as such. So when you have them actually scanned, you're able to see the sinuses which appear typically black. Now, one of the limitations of three-dimensional imaging when it comes to CBCT is the fact that you're not able to differentiate the contrast of soft tissues. But the only area in which you would possibly end up with a little bit of or a lot of soft tissue contrast is in the sinuses, because sinuses typically have nothing but air. And if there's any kind of soft tissue accumulation, it would appear as gray, as you see on this view right over here. So it is important to note that whenever you see some sort of gray material in the floor of the sinus, one of the key things to remind yourself is that you have to be able to either rule out a pathology that is attached to of odontogenic origin, that is attached to a tooth, or make it a point that it may not be attached to the odontogenic origin and it's a pure sinus pathology. So there's a vast difference between the two. Another critical structure, I did mention the ostium. Ostium is a little canal that you see right over here, bilateral. The patency of the ostium indicates the drainage of the sinus into the middle meatus of the nose, of the nasal cavity. So there are two schools of thought when it comes to ostium, the patency of the ostium. There's a group that believes that the patency of the ostium may not affect any implant treatment as such. If there is an infection, there is an infection, but it does not affect implants at all. Whereas there's another school of thought that believes that it does matter. So it is up to you the way you want to perceive it. That's fine. I'll let you be the better judge for that. But typically, as a standard protocol, if the ostium is not patent, which means if you see gray matter, if you see gray area all the way in the sinus, then it clearly indicates long-standing or a chronic sinus disease. Ideally, you would want that to clear that off before you do any kind of procedures. But again, that's a matter of choice it's for you to decide as a clinician when you see the patient. Now, the paranasal sinuses, like I mentioned, is a group of sinuses. So you have the sphenoids all the way at the back. The sphenoids are typically just like any sinus. It is clear, nothing extraordinary, unless and then you have the web-shaped structure that you see over here, which is the ethmoid sinus, also a group of the paranasal sinuses. So if you have these sinuses captured, please do make it a point to evaluate that and make sure these anatomical structures are free and clear of any occult pathology. So let's take a quick look at the bone per se and say, what do we mean by assessing the quality of the bone? So when we look at the quality of the bones, one of the things that I did mention was that we do not use the traditional methods to assess the quality of the bone. So what other methods can you use? It becomes a much more detail than actually just assigning a number to the quality of the bone. So now, for the sake of interpretation, we would divide that into the cortical bone and the cancellous bone. So the cortical bone and the cancellous bone, as we go through the entire slice, you can see everything changes quite a bit. So as you go posterior, you notice that the cortical bone is slightly more thicker than you have on the lingual side. You have a little bit of thinning. You do see a little bit of, in fact, a little bit of lingual undercut. So also very important. So you can clearly see that there's one thing missing. The cortical bone is very intact. It is very well done. So it's very well contained as such. Now, the cancellous bone inside, in fact, indicates a density of the bone. Now, this is where a little bit of confusion does exist. This is where a little bit of confusion exists when it comes to cortical bone as a cancellous bone as such. Michael, as a check, Can you hear me well?
Yep, sounds good now.
Okay, great. All right. So in the cancellous bone area, the cancellous bone is contained over here. Now, if you do not see any trabecular pattern like you notice over here. Now, I do have another image to compare it to as well. We will get to it, which means there's less trabeculation, which means there's less density. So it's a little bit more detailed evaluation of the areas, of the cross-sectional areas. So I'm scrolling through to see if there are any other areas where the cortical or the cancellous bone and the cortical bone changes. And you notice as I come towards the foramen, I do get a little bit more cancellous bone within the areas. You see the mental foramen right there, but there's also some loss of the cortical structure. The cortical structure indicates one thing. The intactness of the cortical structure indicates the integrity of the implant site as such. Now, if there's any thinning, and let me show you a clear area of thinning over here. Let me bring you right into the midline and show you. This is how thinning of the cortical bone would look. What does that mean? What that means is that it is kind of resorbing. Now, when it's resorbing, it loses its intactness. It loses its shape. Now, you can clearly see that it does not just lose its intactness, the thinning of the cortical bone, but it also loses the shape of the crestal bone as such. So there's a huge impact on the crestal bone, and this can be evaluated by looking at the cortical bone. Now, this is a little bit unusual because of something else that's happening over here, which you can clearly see the soft tissue. But there's a very, you can clearly see this whole thing, how this is thinned out, how the teeth has in fact accommodated with the area of the thinning. Now, typically, if there are no external factors, unlike over here, if there are no external factors, this indicates osteopenia. Osteopenia is very common in middle-age, not middle-age, postmenopausal women. So when you have postmenopausal women, it is probably a good idea to look for osteopenia. What else would you look? Osteoporosis. If osteopenia is present, there's a very good chance that you might also find osteoporosis. So if there's osteoporosis, you would probably see less cancellous bone. Now, in this case, both the signs indicate that you have less density of bone, both in the cortical structure and also in the cancellous structure. So that is a clear indication of osteoporosis and osteopenia. Now, what else can we see? You can also see bone marrow spaces. Now, bone marrow spaces can be a little bit tricky when you try to do, especially identify the nerve canals and stuff, and certain other anatomical structures. Now, in this area, you can see this is actually the lingual foramen right here to the geniotubical. You can clearly see that there is a bone marrow space, and these bone marrow spaces, especially in the areas of canals, can be a little bit confusing and give some false positives. You can see the canal area. This is the canal right here. You have a little bit of a bone marrow space right around there, slightly medial to it. So for that reason, you have to be aware that you do not get caught up with false positives when it comes to bone marrow spaces interfering with your interpretation. So now it is very common to see all these things as age proceeds. So elderly male and female, you could see constant osteoarthritic changes, which could cause thinning of the cortical bone, loss of cancellous bone, occurrence of bone marrow spaces, which are slight pockets, and these pockets have to be just negotiated with. Now, it would be unfair to call one area completely, because you judge a patient as osteoporotic or osteopenic as unhealthy for implant procedures, because this is very common as age proceeds. So they may not be exactly be unhealthy. It's just a matter of actually knowing that you do want to look at these things as a matter of knowledge, so that you pick the right implant, you do the right planning, and so forth. One of the easiest way to understand the cancellous bone, the cortical bone, and the bone marrow spaces, and any kind of osteoarthritic changes, is to check their drug history. Most patients who have any of these would be on some sort of drugs, which would indicate that there are other systemic issues. Now, since we are in that area, another critical structure that I spoke of in the maxilla, the incisive canal right here, you can clearly see it's patent. It goes into the floor of the sinus right over there. So pretty well described. Now, the incisive canal, as the name indicates, have incisive artery and incisive neurovascular bundle. So just an important region not to violate. Generally, if you end up violating that region, you probably end up perforating into the floor of the nose, which is not what you want. So as a quick run through, I'm going to go through on the contralateral side just to check if I'm consistent with everything. Now you can see some cancellous bone. See how within the mandible itself, when you go from one side of the mandible to other side of the mandible, the structure of the bone changes. So it is a fairly good idea to compare the contralateral side and make sure that your diagnosis or your implant planning is in line with what is required. There's inferior alveolar nerve canal that you can identify, one of the very easy structures to identify. Now, inferior alveolar nerve canal has a superior border and an inferior border. The easiest way to identify inferior alveolar nerve canal is to look for the superior border. Now, when in patients with less dense bone, like what you see over here, it is very common that you may not be able to track the canal in the entire length. Now, there is a propensity for a lot of people to re-image the patient, thinking that it's probably something to do with the images or the implant planning software, which you see here. No, it has got nothing to do with that. Probably the images were good, unless you see particular problems with the image. Probably it is just the way it is. And if it's not there, it is not going to appear, even if you try to image a few other times. So very critical to note that you have to keep an eye on the top of the canal, and that cortical structure indicates a path of the canal as such. Now you can also trace this canal as if you wish to. That is very easy. It's a matter of choice whether you want to do it or not. It just seems like it's taking a little bit longer than expected. Oops. Let's just move on to another image in the meantime. So I was trying to show you certain structure. We will definitely come back to it. Actually, I have a much better picture over here, and I'll show you. The canal is much more well defined. What you see over here is an implant area and an implant site. That is in consideration for implants. Now, in this case, it is if you look at the cross-sectional slices, see how good and intact the cortical slices are. They are absolutely intact over here. They show they are very thick, which means it's a very healthy bone. And you also see a lot of cancellous bone. You see a lot of cancellous bone right over here. You also see the mental foramen very clearly. You can see the superior border. You can see the entire circle. So in a few images, in certain views, you may be able to get a little bit more of cortical bone and the cortical structure of the inferior alveolar nerve canal, indicating a healthy path. You can also see in the segmented panoramic view that you see over here very clearly in relation to implant. I've already placed the implant. I didn't want to. I wanted to try to spend as much time with the images. We'll definitely work with the implant as well. So you do see it's slightly above the cortical bone, about the inferior alveolar nerve canal. That is the top of the canal right there. So you can also see the cancellous bone in here. The cancellous bone clearly indicates the healthy structure, which means there's dense bone. You can also assess the angulation over here, which is clearly there. And of course, you can adjust. We'll get to the implants as soon as I finish this component to it. So very, very important to know the angulation as well. So once you start with the implant planning, now it becomes a matter of choice what kind of implant you pick, what kind of place or what kind of guided surgery that you are doing. That is all an individual matter of choice, not the images, nor the planning software determines that. It is the patient, it is a patient's anatomy that determines that. While you place implant, few things to consider is the location of the implant. After placing the implants, it is imperative to look at the axial slices to make sure the implant does not perforate the lingual or the buccal cortical plates. So the best view for that is what I'm doing right over here. That is the best view to assess that there's no perforation. You know, it might be a little bit too close right there. You can see it disappears though, although it doesn't perforate. Now, you might have a different way to do it. It is absolutely fine to pick the way for you to do it, but axial slices do have an important role. Now, when it comes to the buccolingual dimension, adjusting the angle of the implant, very important. You know, you have to be able to adjust the angle of the implant depending on how you want it to be placed. Also, location of the implant in the implant site itself is important. Do you want it close to the ridge, to the crest of the ridge, or do you want it a little bit further down? Because you might be doing some sort of ridge augmentation and that bone may not be available for you. So another critical thing to worry about is how much bone is available, and in that case, where do you start your implant from? So the size of the implant is determined by the site, by the angulation, and the type of the procedure that you pick. So it's a very simple process. Like I said, it doesn't you know, and typically as a process of continuous evaluation, I would recommend evaluating the entire jaw just for the sake of completeness. Now, there's a little bit of a interesting factor in this particular slice. So what I will do is I'm going to go through the cross sectionals, and I will go on to the contralateral side. I do want to show you how the bone differs. Now, notice how the bone was much healthy on the previous side, but when you come to the contralateral side, I'm not saying it is unhealthy, but you would see something curious. You would see some amount of dense bone. Now, it is not unusual. See the amount of dense bone that's there. Look how dense the bone is. So even within, does that mean that is an unhealthy place? It's not. It just happens. These are called dense bony islands. These are anatomical variations, typically, unless there's no systemic condition or drug-related or any kind of drugs that are used to treat any underlying systemic diseases. These are also visible. Does this mean that they are not good implant sites? No. In fact, they are probably a better implant site in case you see dense bony islands. Nothing critical, because one of the easiest way to judge that is you don't see any expansion in the buccal. If it was pathology, you'd probably see some expansion in the buccolingual dimension. You don't see anything. It is a little bit further away too, in fact. So nowhere near the implant area. But the reason I show that is because this can happen anywhere, anywhere in the mandible. Anyway, a few things to note when it comes to this. Well, probably by actually restarting, we can go over a few things just as we did. One of the critical things that I usually do when I get an implant site, when I do an implant site or implant planning, is that I make sure that I get all the anatomy that is captured in the image. And sometimes you might have to do a little bit of adjustment just to get that. You would also have to adjust certain areas, as you see over here what I'm doing. Please be careful that the panoramic reconstruction that you see is not a true panoramic. It is actually a reconstructed panoramic. So for that reason, it is very critical to know that it's not a real two-dimensional panoramic. So any kind of measurements that you make out of it may not relate to a two-dimensional panoramic. And either way, there's no reason to move to a panoramic view because you already have the cross-sectional views. The cross-sectional views are the most important component to doing the implants as such. So if you want to place implants, what you would typically do is you would pick the slice which you're using to place the implants, and you can see everything moving accordingly. And once you do that, you identify the slice, and hypothetically, I'm just going to pick, say, for example, just right over here, you click on the implant, it loads up a whole, and I'm randomly going to pick an implant to all the relevant factors that I mentioned, which is basically containing it within the crestal, within the buccal and the lingual cortical plates, making sure the angulation is oriented according to the way you're planning to load the implant. You're not in violation of any critical anatomical structures. You are not perforating not just buccal lingually, but also any adjacent structures as such. In this case, I just picked up a random place. The true implant site is over here. Now, it is also imperative to note that the anterior mandible is another area where you see a little bit of more thinning of the bone. And I've mentioned this, I just want to reemphasize the fact that the more thinning of the bone than the posterior area. So to assess the anterior area, it is conventional wisdom that you do need three-dimensional imaging to do any kind of radiographic planning or virtual planning for the sake of doing radiographic guides or guided surgery. Now, there is a slight misconception when it comes to anterior region that these areas are easier for implant procedures, hence the need for three-dimensional imaging or radiographic guides, or are not, or guided surgery is not critical. It may or may not be, but I can tell you this much, that three-dimensional imaging is absolutely required when it comes to implant planning, and it closely relates to the fact that it is the standard of care. Now, I did mention there are a few things to look for always. I do want to reemphasize as we go through the final minutes of this, I do want to reemphasize on a few things. One is periapical pathology. If the adjacent teeth happens to have any kind of periapical pathology, like in this area, if you look, you don't see anything. They're all adjacent. The adjacent teeth are pretty healthy. So if there's any periapical pathology, please be careful that unless and until that is taken care of, you might have issues even if you do any kind of implant planning in the adjacent areas. It is very common to see that an infected tooth could create potential problems in future, as opposed to a healthy side, which was once a healthy side and was just turned unhealthy. It's not uncommon for the disease process to happen later. So that is one thing to be important. Second is what field of view that you use. You could use any field of view. Ideally, you would, if you're doing a single tooth implant, you probably might not want to expose the patient to an entire large field of view. You just want to be a little bit localized. Guided surgeries have own protocols, and I'm sure Blue Sky has its own protocols as well, where it determines what kinds of fields of view are needed. The resolution of the images. The resolution of the image, I just want to mention this for one particular reason. The resolution of the image is important, but there is a little bit of leeway over here. Unlike endodontic imaging, when you see the resolution of the image, when it comes to implant imaging, you probably do not need high resolution images, which basically means a sub-millimeter scans. You can probably get away with 2, 3, even up to 4 millimeter scans. So there's a huge advantage when it comes to resolution of the images by keeping the images a slightly of moderate resolution. And one of the biggest advantages, if you have any restorations like this, you see over here. In this case, the resolution was kept into a very modest extent, so that way there's not much scatter, there's not much nuisance in the images or noise in the image coming from these restorations. So as a protocol, it is recommended to know not to keep the resolution high and just enough for what is recommended by the radiographic protocol that you're using, by the surgical protocol that you would be potentially using in terms of guided surgery as such. So those are all the critical things that that I wanted to bring it out to. I know this is a short webinar. I apologize for the technical problems, but at this time, I do want to keep this open for any Q&A. I will be available. We have another 15 minutes. If you want me to talk about anything further than that, I will still be available.
Okay, there are a bunch of questions that have been coming in. Some of them you've touched upon, but let's go through some of them.
Sure.
Do you believe that CBCT is reliable enough to judge the thickness of the cortical plate, or should we resort to conventional CT in critical situations?
That's an excellent question. Absolutely, CBCT is. In fact, I'm going to take this a step further, but I want to answer with conviction that CBCT has better resolution than regular CT. So there's absolutely no indication that the regular CT will yield better results. In fact, the CBCT will yield better results because there's no way that you can get a 1 millimeter or a sub 1 millimeter or a sub millimeter scans out of a regular MDCT. So to answer the question, it is reliable. All measurements made on CBCT are one-to-one. There's no magnification factor or adjustment factors. In fact, on a regular CT, the slice thickness would be much higher, and you use a certain mathematical scale to interpret those images. That problem does not exist with CBCT at all. So it is absolutely reliable, and it is the way to go.
Okay. Can you speak a bit about the accessory foramen, and are they all necessary to avoid with implant placement?
Okay, the accessory foramens, like I said, this probably literature indicates this a presence of probably on the lower 30%, like 30, 32, 33% of individuals could probably happen to have accessory foramens. Now, that said, it is not, I haven't come across too many of them, although the literature indicates pretty much a high number, but it is good to know. It is good to know because accessory foramens sometimes end up. In fact, I do want to take you to that slide that I was showing you, and something that I did not touch upon because of the sake of time, and this is probably a good time to show you that. Notice in this case how the canal comes anterior, and you see the foramen over here, and then if you go slightly anterior, you see that the canal extends into an anterior extension. Now, it's very possible that this could exit through an accessory foramen, and it is for that reason that we would always prefer to look for the accessory foramens. It is important in terms of implant planning because you do want to avoid it. Typically occurs around the premolar canine area, the first premolar canine area, right around that mental foramen, but and typically exiting onto the buccal side. I've seen lingual as well, but it's not uncommon to see it, but majority in the buccal side. But at the same time, it is critical to notice that it's not a good idea to disregard it and intentionally violate it. So it is a critical structure if present.
Okay. Another question that came in: why are we so close to the nerve? Why not angulate more lingually and stay 4 millimeters away with a smaller implant?
It is a matter of choice. I just use this as so please do not use this as a template for you to do the implant planning. I mean, I just picked something just for the sake of demonstrating the tools that are present, the type of the type of things that you need to keep in mind while doing it. So you're right. It could be close. It could be away. It is totally up to you. I apologize if I was sending any mixed messages there, and thanks for pointing that out.
Okay. Is there a way to distinguish an anterior loop from a continuation of incisive branch of inferior alveolar nerve?
You use the same principles that you use for looking at a canal. When you look for the cortical borders, which is the round-shaped structure that you see, just like over here, and that's the same criteria that you use. You would look for that, and if it happens to be continuous, you just follow until it ends. Sometimes, most of the time, it has a dead end within the cancellous bone itself and does not form a foramen. Sometimes it does form a foramen. I've seen an unusual case where it even it joined the contralateral side, a loop or anti-extension for the contralateral side, and joined it in the midline. But that's very rarity. But you look for the same principles. You use the same principles to identify a canal and a foramen, to look for accessory foramen and an anterior extension.
Okay. Can you summarize some of the most common mistakes that doctors that occur when analyzing the CT scan?
So that's actually a fair, that's a very good question. The good news about that is not a whole lot of people are making any mistakes. So that's a great thing. The most common things that I see is, one is there's this, and we haven't touched on this, with the density of the bone has become slightly a little bit confusing because the traditional density measures such as D1, D2, D3, D4 did not apply over here. We are able to now look at, there is this misconception, oh, maybe this type of imaging is not the right way to go. That's not true. In fact, the D1, D2, D3, D4 bone, those kind of bone classification was based on a different criteria. In this imaging now, you don't need to know those numbers, but you're able to see much more detailed structures like trabecular pattern, osteoporosis, lack of trabeculation, if you have osteopenia, thinning of the cortical bones. So it is a little bit more detailed. So one common mistake that I generally see is trying to apply those things. Second, there's also a little bit of misconception about using Hounsfield units. And for those of you who know, this is nothing but a tissue density measurement, but there's a slight problem with this. Hounsfield units are designed for regular CT images, not CBCT images. Now, softwares, even like Blue Sky Bio, does give out Hounsfield units. It is not because Blue Sky Bio software is bad or they are doing something wrong. They are actually doing it right. The software has the capacity to take images from CBCT units as well as multi-detector CT units that you see in the hospital. So if it is a CBCT unit, those numbers are not reliable. Now, there are some bench studies that indicate about gray levels and things like that, but as if right now it is not mature, and I advise people to stay away from it. There are a few times when I've got questions regarding, hey, what do you think about this number? And it's a CBCT image, and I said I don't have an opinion. You shouldn't be looking at it, because that could give you a false positive about that. So far, and that's a limitation of the science by itself. It's not a limitation of the type of the unit that you use or the manufacturer of the unit. It's just a limitation of the physics by itself when it comes to CBCT. One other common mistake that I end up seeing is, and I wouldn't say it's common actually, or when it happens, is making measurement and then finding out the measurement does not correlate. The problem is there is a tendency, and in this case, not because we're consistently using only cross-sectional, which is what I always recommend when it comes to implant imaging. Now, in certain other softwares, one of the common mistakes that you do is you end up making measurements on a panoramic view, such as this, which you can change in slice thickness and things like that. The problem is what you see over here is a panoramic slice, which means a slice between the buccal and the lingual cortical plate. So it could be just one slice, and then surgically, when you go slightly buccal or slightly lingual, you end up getting a slightly different measurement. So this is critical also when it comes to designing guides. You do not want to be making measurements from a reconstructed panoramic view and then trying to correlate that into the guide or where you want your guide holes to be and things like that. So in fact, you would, as you work through it, you will get an idea how that correlates in terms of implant placement. Because what would happen is you could end up making a measurement slightly over here, and your implant might be going in a completely different location, which is slightly anterior and slightly buccal, and those measurements don't correlate. But those are probably the only things that I've so far heard. The only other times that I do see some issues is probably not going through the entire image. Please do look at the entire image. If you get, even if it's a single tooth implant, like in this case, this area, fortunately or unfortunately, you do have the entire scan. So please do look at all those images as well on the contralateral side.
Okay, what is the radiopacity on the left distal to the 17 area?
So this is a dense bony island. This is the one that I brought that up, and I actually showed it. Let me actually go to that area, and there you go. Sorry. So what you see over there is a dense bone and nothing but what you see over there is just dense bone. This is actually a textbook case to show that the internal structure of the bone could vary even from one side of the jaw to another side of the jaw. So it is nothing but dense bony island. In this case, there's no expansion. It just seems like it's very localized and does not affect the patient. Now, this is just an anatomical variation. But there are a lot of other pathologies that happen and everything, but in this case, it's not that. But it's just a dense bony island.
Okay. There's a density level measurement on the lower right corner of the page you are showing. Is that measurement useful?
No. If it is CBCT, no. If it is a regular CT, yes. And that is exactly the density level that is said, when we talked about the Hounsfield units and as such. As so far, there's no correlation between those numbers and the tissue density as such. Will it come up? I think it is about to. It'll be very soon. The software will get mature enough, and I'm pretty sure folks at Blue Sky Bio are probably looking into how to correlate these things into tissue density as well, tissue density measurements as well. But so far, no. As far as CBCT is concerned.
Okay, I think that pretty much uses up the time allotted for the presentation. So I wanted to thank you for the presentation, a lot of very useful and helpful information. And thank everybody who's attending. We have a fantastic turnout from a lot of different locations. So thanks for everybody for taking the time to attend the presentation. And of course, Dr. Kotal, thank you very much for giving the presentation.
Thank you very much, everybody. And I apologize for the couple of technical issues that we had. And okay. For the sake of completeness, I will be waiting for the next 3 minutes, just to make sure I'm here for the full hour.
Okay, and I am posting the link again for the webinar attendance form. So just a technical issue. In the chat box, there's a link for the webinar attendance form. So fill out the form so we could send you the CE credit. And as I mentioned at the beginning of the presentation, this is part of a webinar series. So there's a lot of very good recorded webinars that are accessible via YouTube and the Blue Sky Bio website that provide a tremendous amount of information on various topics connected to implant placement and guided surgery. Okay, here's another comment that just came in.
Sure.
Sometimes I find empty spaces in the mandible. Can you please show us an example of focal defects?
Okay, those empty spaces are what I referred to in the early, in the earlier part of the webinar. Let me see if I can see that. Those are usually bone marrow spaces, just like how you saw. This is a clear example right over here. You can see the canal. This is the canal. This is the foramen, but you see an empty space right above that. So that is nothing. It is a bone marrow space. What typically happens is because of tuberculation, sometimes there are some empty pockets that happen, and this is very common. The only problem is, like in a location like this gets a little bit confusing when it's right next to the canal and right next to the canal. Now it could be superior, it could be inferior, but it's it's a good possibility. Now typically these empty spaces, these bone marrow spaces, can happen in any type of bone, but generally it happens usually when in a slightly aging population. As age proceeds, we see osteoarthritic changes within the cancellous bone, and that's when there's a slight breakdown of the cancellous bone. There's a breakdown of the tuberculation as such, and that's when these pockets or spaces sort of looks like these air entrapments, but it's not really air entrapment. It just looks like that. That happens, and they are nothing but bone marrow spaces. Is it contraindicated for implants? No, it's not contraindicated for implants, to my knowledge.
Okay, I think we're pretty much wrapped up for the evening. Thanks again for the presentation, and thank you everybody for attending.
Thank you, Blue Sky, for this opportunity.